Welcome to the deep dive. Today we are plunging straight into what many experts are calling the single greatest threat to the core mission of emergency care. And that's the crisis of emergency department crowding and access block. We've pulled together a stack of the latest research, guidelines, and flow principles, all tailored for you.
And we have to start by defining the enemy correctly,
Right.
because the sources are absolutely clear on this. Crowding is not an ED failure. It's a complex, system-wide capacity problem.
Meaning the whole hospital.
A whole hospital. Demand is just. It's exceeding the ability of the entire system to absorb it. And the core driver, the real bottleneck, is exit block.
The inability to move admitted patients out.
Exactly. No physical beds, no nurses, no one ready to receive them.
So if they can't get out, we're trapped. Okay, so our mission today is to cut through all the noise and distill some truly actionable strategies. We're talking flow principles, communication scripts, things you can use to mitigate these huge patient safety risks when you're working in that kind of environment.
Let's unpack the core reason we have to act, which is, the moral imperative. This isn't just an inconvenience. Crowding kills.
It's that direct.
It's that direct. The consequences are lethal, and we have the data. The most shocking statistic we found: for every 72 patients who wait in the department for longer than 8 hours, one will die.
1 in 72. Wow. That's not a hypothetical risk. That is a quantifiable mortality penalty.
It is. And it correlates consistently with all the things you'd expect. Poor patient outcomes, higher mortality, more morbidity, and of course, a much higher risk of medical error and litigation.
Because you're trying to deliver critical care in a hallway.
In a hallway, in a makeshift bay, in places never designed for it.
And this environment, it sort of creates its own failure loop, right? The literature calls it the crowding vicious circle.
Yes, exactly.
Can you walk us through that cycle?
It's a closed loop of toxicity, and it always starts with output failure, which is our exit block.
Okay, so patients can't leave.
So the space stays occupied, which leads immediately to input failure. Clinically, that's ambulances stacking up outside. It's triage being unable to assess the next unstable patient because there's physically nowhere to put them.
And that delay.
That delay then causes throughput failure. Patients wait longer for everything, they deteriorate in the waiting room, and their overall stay gets longer, which of course just worsens the original output failure. It feeds itself.
The patient safety data is, it's horrifying, but that's only half of the story. The systemic failure has this profound human cost for the staff. The sources kept bringing up moral injury and just this deep, deep burnout.
Absolutely. When you are repeatedly forced to provide what you know is substandard care because the system has failed, that causes profound distress. And this unsafe environment is directly hitting retention all over the world. We're seeing staff choosing to work less than full-time just to make their career sustainable.
And there's data on that risk, right?
There is. We found survey results showing nearly 74% of respondents have considered changing their working patterns. A full half are planning on reducing their hours. Half. If we don't fix the crowding, we risk a complete collapse of the EM workforce. The job is it's unsustainable.
Okay, so exit block is the systemic culprit. We know that. But what can the EM team actually control inside its own four walls? Let's focus on throughput.
Correct. The main operational goal for the ED has to be minimizing the time each patient spends with us. That time is directly correlated with better outcomes.
So we start at the front door, triage, and what the sources call front loading.
Right. And it's not just about the basics. We need to optimize triage, so a proper assessment happens within, say, 15 minutes of booking.
To reduce that risk from the unassessed patient.
Exactly. And you use that time for front loading. We're talking about initiating those basic steps that save hours downstream. Giving analgesia, starting a fluid trial for sepsis, getting those time-consuming urine and blood culture samples right then and there.
And this works even better when you get senior clinicians involved earlier.
Yes, the sources are huge advocates for having a physician or a senior clinician in triage. It's shown to be especially effective in pediatrics, where rapid diagnosis is just so critical.
Because they can initiate investigations and streamline the flow right away.
Right. They can identify the few who need immediate resuscitation and get the others on the right pathway from minute one.
And that idea feeds directly into the rapid assessment and treatment model, or RAT.
RAT is all about a time-limited senior assessment of new arrivals to find those quick wins. It's not just about cutting the wait time, it's about the quality of that first decision.
So you're trying to discharge the minor cases quickly.
Or redirect them. Or, for the unstable patient, you immediately start their complex management The faster you make that call, the less likely they are to become a complex boarder later on.
Okay, let's dive into something that feels really counterintuitive, a clinical habit called batching. We've all done it. You group your tasks, signing off referrals, writing discharges at the end of a shift because, it feels efficient.
It feels incredibly productive. You clear your desk. But this is where the system effects get you. While batching increases your individual productivity, it paradoxically makes boarding worse.
Oh.
You're creating a massive, unpredictable spike of admissions that hits the inpatient wards all at once. They can't staff for that kind of random, huge influx.
So we're trading our own perceived efficiency for total systemic chaos.
That's a great way to put it, yes.
So what's the alternative?
The safer, more predictable approach is a continuous flow model, or CFM. It's proactive. The North Bristol system is a great example.
What do they do?
They hardwired a requirement to transfer one patient per hour to the acute medical unit and one every 2 hours to the acute frailty unit. They have to staff dedicated transfer teams around the clock to meet that commitment.
That's fascinating. So it forces the system to constantly pull patients instead of letting them pile up until a shift change.
Exactly. It smooths out those unsustainable peaks that always seem to hit between midnight and 2 a.m.
And that transition really highlights the priority. Getting patients out of the ED, those output interventions, they have the biggest and quickest impact.
They're the most crucial, without a doubt.
But that means tackling the organizational culture outside the ED. How does an EM team get the authority to enforce flow standards on specialty teams who have completely different pressures?
That is the political challenge, isn't it? It requires clear, collaborative, internal professional standards, IPS.
Okay, what do those standards need to define?
Two critical things. First, precisely when clinical care responsibility officially transfers after a referral. And second, what is a timely initial assessment by that specialty team? You have to measure their response time from the moment of referral.
So the risk transfer begins when the referral is accepted, no matter where the patient is physically located.
That's it. That is the fundamental need for a pull mentality from our inpatient colleagues. They have to own the acutely unwell patient. Emergency medicine is the safety net for the patient, not the dumping ground for the system's failures.
Let's talk about when the system fails completely. Extreme crowding. That's when we get to the controversial last resorts, full capacity protocol and boarding.
Right. And the sources offer strong but very cautious support for them. Boarding being, moving admitted patients toward corridors before a bed is officially free.
And the framing here is critical. These are the least worst options.
They are not solutions. They are temporary tactics designed to distribute risk across the entire system.
Distribute risk. That's the key. You're choosing between two terrible options.
Precisely. You're making a risk-based decision. An admitted patient boarding in a ward corridor, while it's suboptimal care, is a lower overall risk to the hospital than a growing number of unassessed, undifferentiated, critically unwell patients trapped in the ED.
So you clear the space for the highest risk arrivals.
You do. And crucially, once that patient is transferred under FCP, they become the admitting team's clinical and legal responsibility. It immediately reinforces that pull mentality.
This brings us to the tools, the things you need in your pocket. Because you can't solve the whole system, but you can use specific language to communicate the risk.
And you have to be definitive, not apologetic. This is about clinical risk management. So you avoid passive language like, we're really busy. You escalate based on patient safety.
Okay, give us the script scenario. You have an ongoing exit block, a refusal of admission. What do you say?
You articulate the systemic threat,
Yeah.
and you demand a specific action. You say, I am escalating this because the department is currently clinically unsafe due to crowding. We are holding number unallocated patients. By leaving this patient in the ED, we are actively diluting the nursing ratio for incoming traumas and arrests. I need you to enact the full capacity protocol for this patient now.
That's powerful. And what if a specialty team is just delaying their review of a patient in the ED corridor?
That's where you use safety-centered risk transfer language. Something like, this patient has a time-critical condition. The ED is overcrowded, and I cannot guarantee their safety or monitoring in this area. I am formally handing over clinical risk to your specialty now. If you can't attend, I need a documented plan for their safety while they wait.
It forces them to engage with the risk you're holding.
Exactly.
Now let's talk about actually mitigating that risk in the corridor. We have to acknowledge what the sources call silver standard versus gold standard care.
A tough principle, but a necessary one. We have to do the most for the most people with what we have.
So what are the practical steps?
First, Prioritize patients by acuity, by their triage score, not just by who's been waiting the longest. Second, ensure higher intensity supervision is allocated to those areas. Third, guarantee basic nursing care, nutrition, hydration, toileting. Dignity is paramount. And finally, run regular documented safety huddles right there in the corridor.
And in that chaos, missing time-critical medications is a huge risk.
A huge risk. We use the MIST mnemonic to prevent those omissions.
Okay, what's missed?
M is for movement disorders, like Parkinson's. I is for immunomodulators, including HIV drugs. S is for sugar, so diabetes treatments. The second S is for steroids. E is for epilepsy, your anticonvulsants. And D is for DOACs, or warfarin.
Missing any of those can cause a rapid, life-threatening deterioration.
Absolutely.
And finally, the simplest tool, but maybe the hardest, communicating with the patients themselves.
You are managing a failed system, but you control the message. Instead of defaulting to, sorry for the wait, try, thank you for waiting. It validates their time without admitting liability or sounding defeated.
And for boarders.
Be transparent. Be honest about the system failure without dwelling on it. Our hospitals experiencing long waits for beds. We have to wait for one person to leave a bed before we can move a new person in.
Okay, let's unpack this. We've established the systemic culprit is exit block. We've detailed the clinical risks that crowding kills, and we've armed you with internal strategies like RAT and CFM and external tools, those safety-centered scripts.
And here's where it gets, I think, really interesting. If we zoom out and look at this through the lens of complexity science,
Okay.
I want to leave you with a concept called self-organized criticality. It's often visualized with the sandpile analogy.
The sandpile analogy.
Okay.
How does that relate to a crowded ED?
Okay, so imagine you're dropping single grains of sand onto a table, one by one. For a long, long time, nothing much happens. A pile forms. Then, suddenly, one tiny specific grain causes a massive avalanche.
Mm-hmm.
The idea is that EDs naturally operate near this critical state.
Mm-hmm.
They're perpetually poised between predictable order and catastrophic chaos.
Yeah.
That one extra grain of sand, that one extra patient, it doesn't cause the crisis. The system was already a criticality.
So the one patient that pushes us over the edge is just the trigger, not the cause.
Precisely. The research shows that these catastrophic crowding events, they follow what's called a power law distribution. They happen much more frequently and are much bigger than our linear models would ever predict.
Which means the traditional approach of just trying to fix it after the avalanche has started is...
It's doomed to fail.
It suggests just adding more resources when you're already in chaos is like throwing water on a grease fire.
That is the implication. The solution isn't just adding infinite resources. It's using your own data to identify your department's specific critical thresholds.
The tipping points.
The tipping points, the patient census, the time in ED, the number of boarders, whatever it is that pushes your system into that unpredictable failure. You have to implement triggers before the avalanche begins.
So what does this all mean for you on the floor? You need to find your department's tipping point. And here's the thought to mull over. How might identifying your own ED's critical threshold, that number where things become unstable change, where you focus your political and operational efforts tomorrow?